welcome all of our guests to Magical Medical Tour. I'm Dr. Glenn Wallman, and I'll be your medical guide today as we travel through the healthcare galaxy, looking for ways toward optimal health. You know, interestingly, today we have a very special guest. I worked in a hospital in an emergency department. As you know, most doctors have their own office, and then they use a hospital. They get on staff at a hospital, and they either take care of an ill patient. And when they do that, they're in the hospital for that time period. But there are other doctors that are in the hospital all the time, like emergency doctors, radiologists, anesthesiologists, pathologists. Most of them are hospital-based. And when you're in a hospital, you start to realize that a hospital is just like a city. There are various people doing many types of jobs in there: doctors, nurses, technologists, housekeeping, cafeteria and food service, pharmaceuticals, engineering, so many things. And what I realized is that the administrator of the hospital is really like the mayor of a small city. And as the mayor, they have many jobs to do. Most of the time, we don't get to speak to mayors. And I thought in our programming, where we're usually speaking with healers, that it might be very interesting to do something different, which I never see, is to actually get the opportunity to speak to a hospital administrator. And my very special guest today is Jim Raggio. I've known him for many, many years. And he is the CEO of the Lompoc Valley Community Hospital in California here. So I would like to introduce you to him right now, Christina. Jim,
thank you.
Welcome.
Thank you, Glenn and Christina.
Hello, Jim. Welcome to the show.
Well, thanks very much for having me.
So, Jim, what I like to do as a medical guide is give our viewing audience.
By the way, I think it's a better description of me, not as a mayor, but as a chief of the fire department.
Well, we're going to get into that. And you could be right. You have so many roles and you're dealing with so many people. That's what I want to talk about. But I'll accept the chief of the fire department. But I think you're so much more. Not that I don't love fire department chiefs. I do. But I'm going to talk to you a little personally for a while and let people know how you got into the healing business or art or profession. And then I'm going to start asking you some medical questions that have to do with, you know, kind of hospital administration. And then we'll get into maybe some of the nitty gritty of what people think about hospitals and what you want to tell people. So the first thing I'd like to do is give you the opportunity to tell our audience how you got into health and healthcare and what took you to the role of a hospital administrator.
Be happy to. Actually, my father was a general surgeon in San Francisco, was someone that actually traditional physician, was in a coat and a tie 7 days a week doing rounding on his patients. Interestingly enough, none of the kids ever wanted to get into medicine because that's what we knew a physician's lifestyle was. I entered college, thought I'd get into engineering. My first semester in engineering, I was asked to design a parking lot to see how many cars could go in this parking lot. And, you know, I remember going back to my dorm room saying, you know, I just don't care. I don't like this. I'm not going to spend my life doing this. And I just went into biology as a major, not knowing what I was going to end up doing. But eventually, after I graduated with my degree in biology, I was actually thinking about, or actually in the application process for a doctorate in biochemistry, and decided I was working in a lab at that time. And one of the individuals I was working with asked me if I would be interested in entering the clinical science program, the clinical laboratory scientist program at Children's Hospital in LA, which I applied for, got in, and I'm a licensed clinical laboratory scientist, which was my entry into the healthcare profession.
Which is where we met.
that's where we met. And interestingly enough, the very reasons why I never went into medicine was watching my dad work got awful hours. One of the first weeks I was in Lompoc, it was just one of those days as I was managing the laboratory. Someone called in sick. We shut the lab down at 6 o'clock. We were on call, or I was on call, and I ended up working like 30 hours straight in the laboratory. And I knew at that point, I was just shaking my head when I went home to get to bed. But it was a good learning experience. I kind of realized a little bit. I had a flavor for what the physicians went through. The reason, and I thoroughly enjoyed laboratory, I still do. I like feeling like I'm doing something to help individuals. I always went home feeling I participated in my own little way to making things better. I don't think I ever would have enjoyed or appreciated that or felt like that if I was in an engineering career. So thoroughly enjoyed the healthcare profession. I really did not aspire to be a CEO of a healthcare district or a hospital, but one thing led to another, and went from the lab to a director of clinical sciences, which was 6 clinical departments reported to me. And then the board asked me to consider this position as a CEO in 1998, and I did.
Yeah, that's a great story. And I actually, to be clear, I got to be a little bit of a part of that. So that was very much fun for me to watch you go through that transition, knowing from my point of view how good you were in the lab and clinical sciences, that I knew that would just be transposed into being the CEO. So I was very happy about that.
And we both made a huge impact on this small community rural hospital. I mean, just as we flash back on that time when they were trying to redesign the emergency department and they had no place for physicians, those kinds of decisions being made in a hallway, vacating my office so physicians in the ER could actually have a place to sleep during their remodel was critical. And it was just fun to working with someone like yourself to make that happen fairly benignly.
Yeah, we did some nice things. I want to talk about the hospital in general and the hospital and a community for a few moments. You work with a lot of different groups, as you said before. I mean, you have to deal with doctors and their egos. You have to deal with nurses, the public, the community. You have to deal with legislators in California, other hospital administrators. All of these things, you have to balance plates and keep everyone happy and get things moving. Who's the most fun to work with?
The most fun.
There was a moment of silence.
Environmental services staff. I don't know if there is a group that I would pick out. I think that part of what my role is to get everyone to appreciate the different talent that everyone else brings to the table to make this organization work. So many times with physicians and our IT staff, environmental services staff, engineering, all of these various departments, we're very fortunate at Lompoc to have some very, very talented people. And sometimes, for example, finance, they can be somewhat anal retentive and, nitpicky to the other people. But I always try to make them understand that the reason why I have the ability to purchase a $300,000 piece of equipment is because that person that you think may be somewhat critical of the way the purchase orders are done or whatever results in us having a finance department that I trust. And in order for me to trust the numbers that they're providing to me allows me to allocate resources, $300,000 for a new x-ray machine. So eventually I think it's just being able to facilitate and make sure everybody appreciates what everybody else brings to the table, because we're very fortunate to have a lot of talented people, and the physicians too. I mean, the physicians are under a lot of pressure. They work in somewhat of a silo. They're educated and trained to make decisions, not so much in a collaborative way, because they really at various periods of time can't do that. And getting them to understand that the bigger picture of the healthcare delivery system, we need to pause a little bit and appreciate everything else that's going around, not just focused on one little small issue that we're looking at. And all of these issues, I think, go with everyone that I deal with throughout the day.
So let me see if I can summarize. ER doctors are the most fun to work with. Is that what you said?
They're a component, yes, with everyone else going.
Oh. All right. I want to talk about how the hospital itself is a community, but it lives within a community also. What does a hospital offer a community?
Well, just so people understand, Lompoc is, we're about an hour from Santa Barbara in a rural area. We're designated as a rural healthcare facility by the federal government. The state considers us urban. But we have about a 60,000, 65,000 population, and the nearest hospital to us is 35 miles away. Whatever happens to the healthcare delivery system in this country, there's no way that a community of 65,000 that's 35 miles away from another hospital will be without a hospital. So part of what we're doing is trying to strategically position ourselves to maintain viable in an ever-changing environment. The community is a huge part of our hospital because we are considered a healthcare district, and we're a political subdivision of the state of California. We operate very much like a school district. And so we have an elected board by the community, and anyone that lives in Lompoc Healthcare District can actually vote for the 5 board members that I report to. I think this is one of the best models of healthcare delivery system because there are no other alternatives or motives. There's no corporate stockholders that we have to listen to or deal with. It just basically we're here to do what's best for our community. We have the ability to get community input. One of the things that we're recently doing is we've had an individual that presented to the board of directors that was unfortunately going through some radiation treatment. She was concerned that the closest radiation center was 35 miles away, and so we started and embarked on developing a radiation center here in the community just to respond to those needs. So
nice.
We've been very, very fortunate. And I think this is really a model delivery system because really we're partnering with everyone, the community. We also, when the state passed Senate Bill 1953, which was the Seismic requirement that all hospitals in the state of California comply with, we have the ability as a political subdivision of the state of California to go to the community and ask for a property tax assessment to fund the construction of a brand new hospital, which we did. And with that, we are very proud of the fact that when the bond measure went to the voters, it passed with 87% voter approval, which today is still a state record. And that's just, I think, a function of the community respecting us, knowing that what we're here to do is provide the healthcare needs of our community. They know we have a very dedicated group of people here, very talented, and it showed in that support.
Good answer. It also, I remember when I was there, we put on a career day for a lot of children in the community. We had all the heads of the different departments come in and meet with the kids and talk to them about their futures. So another thing the hospital offers a community, especially in this times when we're looking at the economy and jobs. There are lots of things that are done like that in a community at a hospital. You said
we happen. Sorry.
Go ahead.
Yeah, we happen to be the second largest employer in the entire city.
Should I ask the first?
I think the school district is.
Okay.
So
You mentioned that you think that this is a good model for a hospital. Yeah. You meet with hospital administrators around the country, don't you? Do you talk about things like this? What do you communicate? And when they talk to you about this model, do a lot of them see that as something good, or versus, say, a Kaiser model or other programs? How does it work when you're with the other administrators?
As it's really the takeaway from me, and I do speak with quite a few. I'm on a number of boards, and I travel quite a bit up to Sacramento, and I do have an opportunity to speak to a number of my colleagues throughout the state. The healthcare district is a good model in a community like ours. Kaiser is a good model, and what I've always been amazed at in trying to come up with a national healthcare delivery system is that healthcare is so regional and so local that it's very difficult to put a single solution throughout this country, because my situation in Lompoc is so different than what's in Santa Barbara or San Francisco Bay Area, where Kaiser is predominant, and they do a good job, but the environment is completely different. And then you take the Mendocino Coast. There's Mendocino Coast Healthcare District. They're out there, a critical access hospital out on the coast, extremely isolated, and providing care to the residents in those Crescent City and those areas. Our environments are so different that I think it's going to be very difficult to have a one-fit-all solution to whatever healthcare evolves into. I think in Lompoc and in our community and in our area, a healthcare district is the best model. Kaiser would never come into a community this small. And so part of the problems that we have as a rural area is the foundation model, which is what Kaiser is. We don't have the subspecialty physician in our area to support a foundation model. So, it's an interesting, so the takeaway, Glenn, really is that our environments are so different. I always come back and say, boy, I'm pretty blessed to be in this area because I don't have half of the problems those other individuals have in their communities.
I have a question, Jim. If I were ever to live around your area, that's one hospital in a 35-mile radius. Is that right?
Yes.
What is the main form of transportation in an emergency?
Normally what happens is people will present to our emergency department, and if we do not have the services that are needed, we transport them down. Right now, our primary referral hospital is Cottage Health Systems, and so we have relationships with Cottage and the ambulance services that we will transport patients down there. And it usually takes about 50 minutes to get to Cottage.
So by ambulance?
Yes.
And what if I need to get to you in an emergency?
Well, there's ambulance services here in Lompoc. The fortunate thing is, in a small community, one of the critical things, and Glenn can speak to this better than I can, but the most important thing of saving someone's life is getting them to a hospital quickly. And in Lompoc, you can get to this hospital in 5 minutes from anywhere in the community.
Wow.
And that's really an added advantage that we have. I remember growing up in San Francisco, you're hearing the ambulances all the time, and good luck with the traffic, the congestion. Yes. You can't get to a hospital in 5 minutes. Right. And, if you have a GI bleed, for example, and you're bleeding out, you need to get to a hospital quickly. And that's the advantage of living in a small community, because we do have ambulances that transport people to and from our facility that are stationed in our community. And that's one of the things I think Glenn was instrumental in improving that service, because it was pretty much a mom and pop thing back in the 1980s. And we orchestrated getting AMR here, or Glenn did, I think, with our ER group to improve those services. And it's been extremely successful. So to tell you the truth, I think from a standard of care, I think we're in much better shape dealing with getting a person to a hospital like ours quickly than you are in a large urban area.
Mm-hmm.
Even Santa Barbara, to be quite honest with you.
Mm-hmm. Yeah. Go ahead, Don.
Continue.
No, I mean that would be my most concern when in any of these smaller areas, and you're absolutely right. Here in Los Angeles, to get to and from a hospital, even though they're maybe 4 miles away from me, it would take me 15 minutes. And if there's traffic, it would take me 40 minutes to 45 minutes.
Our first child was born when I was completing down in Los Angeles, and I was completing my internship in clinical science at Children's. Excuse me. And, it took us 25 minutes to get to the hospital where our son was born. But that was just accepted. I mean, that's what happened. You planned for it. But in Lompoc, I'm a half a mile from the hospital.
Oh, that's wonderful.
So have more kids.
Yeah. No, that train left the station.
But now he's right in the hospital. It's too easy now.
Yeah.
If only he could give birth.
Right.
Well, actually, I got in trouble with my wife when she was delivered our third child here in Lompoc, and she's going through the delivery, and by this time it was old hat, so I just went back to work, and I ended up getting the stat page to please go to OB. So I ran down there and watched our daughter being born. I'm still living that one down.
Oh, my.
Jim, what's the most gratifying part of being an administrator?
I think making a difference in this community. My time on this planet, I think I've made a positive difference. And, we've built a hospital for a community that's going to last for 60, 70 years. Made a lot of positive changes. I think we've, over the past number of years, actually have really focused on providing quality care. And I think I've been fortunate to be part of that. And I just find it very, very, I'm proud to be involved in it, and very happy and satisfied really on my career choice.
What's the most frustrating part?
I think people that, physicians and some staff that really can't see the larger picture, where you almost see them walking to a cliff and are about ready to fall off. And, I think physician integration, physicians, where the delivery system is right now, physicians and hospitals need to integrate. And that's coming from pressure from the federal government. I think really some of the, and state government, the thing that causes all of these frustrations is that, our government, whether it's the state or the federal government, find it a lot easier to decrease reimbursement to hospitals and physicians than it is to deal with wholesale changes to the delivery system, which are very difficult to come up with. And as a result, we're in this constant battle of, cut, because they just don't want to deal with some of the more difficult issues. The end of life issues, the amount of money that's spent on the end of life. Our government has a very difficult time dealing with that. It's horribly expensive, and there should be some objective criteria on, do you put a liver in a 90-year-old individual? The cost associated with that, but those are very difficult decisions for anyone to make, and I think that's kind of problematic. And so the pressures put on from state and federal government are resulting in us having to really take a look at the efficiencies of the operation, and that impacts physicians in what they can or cannot do. We have physicians here that, there's a federal mandate on this electronic health record. Nobody argues the point of having records electronic. Unfortunately, trying to put that in place in a small rural community where some doctors don't use computers, and you've got other ones that are right out of a residency that are waiting for the computer. So trying to facilitate all that gets very frustrating.
I got an email from someone watching the show who wants to know, maybe this would be kind of a simple question that segues right into what you were just speaking about. The question was, with insurance companies, I'm going to read this, with insurance companies demanding more from doctors in areas and time, which sometimes translates maybe into eliminating some medical steps or patient things a patient might need. Hospitals are plagued by cost and relief for payment. What can hospitals do, if anything, to assist doctors and nurses in their work based on insurance processes?
I think understand the hospitals are best suited to actually navigate through this, cesspool of regulations. Mm. A lot of the times the physicians don't have the time or the energy to actually learn those, and it's always a reactive posture they have with some regulation coming out. Hospitals, I think, because of the staffing ability and our need, we stay focused on changes in rules, regulations, and that's where a hospital, I think, can help. I've never really been in a situation where I have ever experienced someone not doing the best for a patient. Fortunately, I think in all my career here, I've never seen a physician not do something because of the costs. We have never told a physician not to do something that is necessary because of the costs. And I really don't think as a country we want that to happen. So I've never really dealing with getting reimbursed is after the fact. We need to be taking care of the patient the best of our means and then dealing with the reimbursement later. And I'll give you just one example. We had an individual that came into our emergency department with aplastic anemia. Their bone marrow shut down. They got admitted to our hospital. They had no insurance. And we took care of them. We transfused $50,000 of blood products. The individual's bone marrow kicked in and started making all these blood cells. The patient was discharged probably 7 days after they were admitted, and with no insurance. And, at some point, now 2 weeks after this patient was discharged, I get a bill from the local blood bank to pay them the $50,000 for the blood products that we used on this patient. Mm. And no one in this country thinks that we should ever or would ever want anybody to turn that patient away. The issue of getting reimbursed for services that we provide is a national issue. I just personally don't think that in that situation, a small rural hospital should have to absorb that loss, which we do now. That's more of a national problem that needs to be addressed, and that's just part of how dysfunctional the payment system is right now in the country. But there's no one that's going to allow someone with chest pain or aplastic anemia or any disease state not to be taken care of in this country. And they do get care. The issue is a reimbursement. And so we're always really focusing on how can we maximize a reimbursement. And then we are in collaborative discussions with the doctors now to sit there and say, okay, if you call up a physician for a consult on a patient, that increases the acuity of this patient's stay. So you're going to get paid more if you just document that. Historically, physicians have just never done that. Mm. And so there's a learning process that needs to go on there. So, to answer your question, I think that as payments go down, the hospital is best suited to educate nurses and doctors and facilitate an efficient way of dealing with anyone that comes into the hospital and get reimbursed for those. Mm-hmm.
Very good answer. Do you talk about regulations coming down from states and locals and federals? Does anything go in the other direction? Do hospital administrators, can they affect change for the better of delivering health care? Is there any chance at doing that, or is it always going to be a downward flow only?
No, I think that there's 474 hospitals in the state of California. Now, those are all kind of spread out into different delivery systems. You have healthcare districts like Wampa. You've got county hospitals, and then you've got UC, the public hospitals, the designated public hospitals, the private hospitals, and the for-profit, not-for-profit hospitals. You have all of those groups that, through our association, the California Hospital Association, get together to try and drive some reasonableness to the healthcare delivery system from a hospital standpoint. We happen to have Dwayne Donner, who is the CEO of the California Hospital Association, has been very involved with developing a response and towards the Accountable Care Act, what impact that would have in California. So we're very proactively working with both the state and federal legislature in just advocating on behalf of hospitals, recognizing it's a very difficult situation, even amongst hospitals. The county hospitals have different issues than public hospitals, the county hospitals versus the UC systems versus private hospitals versus not-for-profit hospitals. So trying to get a single voice to deal with Sacramento and Washington is really important. And we've been successful in doing that.
Jim, in your hospital, do you have, are you also immersed into the alternative, what people would call the alternative medicines as well? Or is it mainly like a lot of hospitals are, which is the scientific, medically based?
Right now, it's pretty traditional, scientifically medical based. We are developing what's called a champion center, which is post-traumatic. It deals with the effects of post-traumatic stress for police, fire, and military. That will have a holistic approach to it, with meditation and acupuncture and those types of things. We're also looking at developing with the Radiation Oncology Center. Part of that process is a wellness center that we're looking at. So hospitals are evolving into that, and we are currently.
That's fabulous. That's really exciting to hear that. I was excited because then it's not really alternative, is it? It's really the holistic approach.
It's more holistic, and that needs to be considered equally as part of the scientific approach to the healthcare delivery system. We recognize that in the community. Our board recognizes that, which is why we're allocating resources to develop centers like that.
Wonderful, wonderful. Congratulations.
At some point, it will all just be called medicine.
At some point. Yeah.
Yeah.
Jim, what do you think is or are some public misunderstandings of what goes on in a hospital? I hear people all the time talk about it, mainly when they get their bill is when things come up, and they start looking at a bill and they say $10 for a Band-Aid, and then they get a little crazy. Yeah. So what are some of the things that you think people have a misunderstanding about, or that you would like to correct in the eyes and ears and minds of the community?
Well, I would like, the misunderstanding is the fact that people complain that an aspirin costs $250. I'd like to correct that misperception. Everybody should accept paying $250 for an aspirin. Actually, Glenn, that is, and that's really not a misperception. That's a fact. Hospital charges are nuts. I mean, they're absolutely crazy. And you can't justify them. They are developed they're a result of the current delivery system. And it goes back to cost shifting. When I gave you that example of that person that came into our emergency department with aplastic anemia, and just for the blood products alone, we spent $50,000. I personally signed a check to Tri-County's Blood Bank at that time for $50,000, and we pay our bills. And that was a bill that showed up to take care of this patient. We had zero money coming in to pay the cost of that. And not only to pay the cost of the nursing care that he received for 7 days. So what happens is we end up taking a look at our private payers, the people that are insured, and you go after the insurance companies and raise rates to the insurance companies at a point where you get paid for some part of those losses. And that's called cost shifting. That has gone on for 30 years, and which is why you end up with an aspirin costing $250, and it makes no sense. In fact, I was up in Sacramento 3 weeks ago, and actually one of our goals at the California Hospital Association is to actually come up with a reasonable pricing policy to deal with this very, very sensitive and valid issue. It's a complicated issue, and it needs to get addressed, and we are working towards doing that. Some of the other things, the misperceptions, is that healthcare, should be less expensive. One of the things that drives me nuts as a CEO is in 1995, the state of California passed Senate Bill 1953, which is the Seismic retrofit bill. That bill just alone, it's an unfunded state mandate that required all hospitals, all 474 hospitals in the state of California, to comply with very rigid seismic standards. At that time in 1995, it was estimated that full compliance with Senate Bill 1953 would cost the 474 hospitals in California $120 billion.
Oh, wow.
That $120 billion is spread over 474 acute hospitals in the state of California. The $120 billion was larger than the annual state budget. The state budget right now is about 80 or 90 billion. And so the state legislature really just dropped in every CEO's lap a $120 billion charge that we had to deal with. And I don't have a problem with meeting seismic standards, but if the state is going to pass legislation like that, they ought to fund it in some way, because it just devastated. And one of your earlier questions, what have we done to proactively deal with being engaged with Sacramento? My response to that was, my response actually in one of the meetings at the California Hospital Association in 1995 or 98 was to all the hospital CEOs in the state buy their own ticket to Sacramento, walk into the legislature, and tell them we're not doing it, and then go home. Unless you fund it. And unfortunately, what's happened, not unfortunately, but there's been a lot of, we've got a brand new hospital building that's being paid for by the taxpayers. But in Santa Barbara County alone, we have spent probably $1.25 billion complying with this seismic requirement. Those costs directly impact the cost of healthcare in this state and in this county and in this country. And those kinds of things, somebody has to pay for those. This is not a market where we can continue to absorb those costs. But we're in an environment right now where, and we should, anybody that comes into our doors, we need to take care of. But it's not like, the federal or the state government want to go buy a car, they'll go to General Motors and pay for the car, pay the cost of the car. We're not even getting right now the cost of the care that we're providing, covering that from some of the federal programs. Medi-Cal or Medicare is decreasing their reimbursement because of the state and federal deficit. It's just easy to cut, and at some point, the whole system's going to implode.
Has to make changes, as you said before. There are a few other things that people get concerned about. People have a fear of hospitals. They hear about infections that you can get. You go into the hospital and then you get an infection from the hospital. And of course, Tell us how a hospital deals with that concept.
And that's the other argument that I had with the California Hospital Association. I think that somebody ran an ad, and it had this mortuary music playing, and all it did was had statistics show up of how many people are being killed in hospitals. And it's not that everybody makes mistakes, but on the whole, I think infections in hospitals are very low. There's obvious room for improvement. Some of the things that we've done to deal with that is, we terminally clean every room after a patient is in there. Some of the federal, so terminally cleaning is they go in, they take all the drapes out, they take the bed coverings, replace them, completely clean the building. But that has a cost associated with it. The federal government and state government want us to test for some organisms like methicillin-resistant Staph aureus, commonly called MRSA. So now we're dealing with people get cultured with this, but they're not infectious. So if we have a nasal swab of someone with this organism, do you put them in isolation? Do you not? So there's a lot going on in this area. But hand washing is proven to be one of the simplest things to do to prevent infections, which there's a huge hand washing program going around, cleaning, terminally cleaning rooms and equipment and so on and so forth. Also, there's some federal regulations which actually are positive because they're scientifically based about dropping infection rates with how they're putting central lines in, making physicians gown, mask, glove to put a central line in. They've dramatically reduced the number of central line infections because of these policies and procedures. And I don't mean to harp that every federal regulation is bad. I think the ones that are really scientifically based, many of the things that you see in ORs about when patients that are going to surgery get an antibiotic, those have had real positive changes because they're scientifically based, and those have had positive impact on the delivery of care. But I would say, all in all, hospitals are very safe. I really don't have any major paranoias about being admitted to any hospital, but we are in an environment where things can happen, infections are there, and you try and just minimize those.
There's always the rumor or the story that the surgeon left the sponge in or the hemostat or something like that. We hear all of these stories, and they think that no big deal. There'll be a doctor cover-up. Nothing will happen. But you and I know we have many committees and reviews of everything that goes on, and things don't get past us. They go to many different people looking at it from different points of view. Do you want to speak on that for a moment?
Yeah, it's something, again, there's called peer review that goes on in every hospital, and it's really mandated. And it's a time where if you're really going to make substantial changes in processes that need to be changed, physicians need to be in a room with hospital staff to take a look if there is an event that occurs, to step back and scientifically just dissect it. And, why did this happen? How did it happen? What failures did we have? How do we prevent this from happening again? Mistakes will happen, and you always have to be understanding of that, but you should never have the same mistake happening over and over and over, and that's a failure in administration, a failure in the medical staff. And so we take a very strong, and I think all hospitals in the country are like this. When issues happen, you take a look at what broke down in the system and correct it, but it's taken very seriously. Some physicians' licenses are jeopardized by these types of things happening. So, and it's more of a collaborative effort with the hospital, the nurses, and the doctors, all really focusing on what is in the best interest of the patient when they're in our care and under our care.
And then there's Joint Commission.
Joint Commission is an outside agency that comes in. Both the state and the federal government come in every 3 years and reviews the policies, procedures, operations. They send physicians in, independent physicians, to come in to take a look at how your facility is running. That's one of the other things that I find kind of interesting is that these so-called surveys are just exponentially growing. We've got now these little sub-surveys of a pharmacist from the state will come in to take a look at our medication administration process. We have a survey of our hearing program for the newborns that are born in our facility. You've got this Joint Commission coming in every 3 years. So they go on and on and on, and you kind of wonder, Joint Commission used to be a consolidated survey that happened every 3 years. Now it seems like we have people walking through our facility all the time. And I personally think that they should just consolidate it all and save some money from a administrative standpoint on the state. Send the regulations out, make sure we're complying, survey us every 3 years. Or more frequently. They're unannounced surveys, so no one knows when they're coming, and that's the best way they should be. And so there's a lot of oversight and regulations that go on.
Fantastic. Listen, I always ask my guests to give a health tip. Most of the people I've had were healers, physicians and acupuncturists and homeopathic doctors, but I've never had a hospital administrator. And by the way, this is we're so grateful for you coming on. It's very rare that we get to talk to a hospital administrator. I think we hear from all sorts of healers many times, but this is kind of rare. Do you have a health tip based on your experiences and wisdom that you could share with us?
Well, if personally, I think it's just moderation. Everything.
Great.
I've always argued. I've always dealt with weight. Ping pong ball, typical guy that goes up, goes down. Getting out of myself. Then I start losing weight. But volume in it's a volume control. There's nothing that is that harmful to us. I think that as long as they're in small portions, whether it's wine, whether it's hamburgers or fish, you just need everything in moderation. And I think that if you can do that and maintain your BMI at an acceptable range, you should be okay. So there you go.
I like that. I heard once that you should take everything in moderation, including moderation. So maybe every once in a while, but I like that. Is there anything in this opportunity that you would like to say to us to teach us a little more about hospitals before we end today's wonderful conversation?
No, I think the other issue that's out there that people need to be a little bit aware of is the integration that needs to go on with physicians and hospitals, and I'm speaking specifically in California. The other misperception is, Glenn, and you dealt with this when you were in our emergency department, that everyone thinks that the emergency room physicians or the anesthesiologist are hospital employees. In the state of California, it's illegal for hospitals to hire doctors. And that's a real problem for people that come into emergency rooms, because you'll get a bill from the hospital for our services, and then they get a bill from the physicians for their professional services. And unfortunately, one of the biggest issues that's out there is that we have no control over the emergency room physicians that we've hired to operate and staff our emergency department, what contracts they can sign. And so you do have situations throughout the state of California that's very frustrating for patients, that the hospital may be contracted, for example, let's say Blue Cross, but the physicians may not. And so you come into an emergency department, the hospital is under your coverage, but the physicians aren't. And then the patients get upset, rightfully so. And we are also working, the California Hospital Association is working on trying to allow us to bill for physicians, at least, that are hospital-based, like the anesthesiologist, like the ER physicians, pathologists. And, really, if you get admitted into a hospital in California, you get admitted through the ER, you go have surgery, you have some malignancy taken out or a tumor taken out of you, then you get to the floor in med-surg, you're going to get a bill from the hospital for all those services, but then you're going to get a bill from an ER doctor, you're going to get a bill from a general surgeon, you're going to get a bill from an anesthesiologist, you're going to get a bill from a pathologist, and most likely you're going to get a bill from the radiologist. And so, that's a dysfunctional system. And, we all need to kind of focus. Christina, don't laugh. The whole system is dysfunctional right now.
Jim, I have to tell you, I have I am from Canada, and my whole family lives in Canada, and I hear them complain in Canada about, all these little bills, the one bill that comes from the government after a hospital stay or something. And I do have a nephew who is also a specialist in Canada. And to hear that, already you're traumatized to a certain point when you have to go into a hospital and, you're needing the urgent care and everything. And then after you leave the hospital, the post-trauma is all these bills that are coming in here,
Well, not only the bill from the hospital, but then you're trying to make sense about all these hospital-based physicians, but then your bill from the hospital shows you're getting charged $250 for an aspirin.
For an aspirin.
And anybody, I'm being facetious about that, but the charges don't reflect the cost of providing the care because of cost shifting. The whole system really needs to have a wholesale, I think the hard drive needs to get reset on the healthcare delivery system in the United States.
On the other hand, good things also happen in hospitals. Lives are saved, limbs are saved, sight is saved, children are birthed. Stuff. Many good things happen in hospitals. Yeah, Jim, one last question, if we have a moment.
Yeah.
Somebody has a problem with the hospital. Do they contact the hospital administrator? Who do they contact?
There's usually individuals that will deal with that. Our quality assurance risk management departments or hospital administration. They could contact anybody in the hospital because most hospitals have policies, as we do, that anybody that has either a complaint or a commendation, actually we take those down and log those and research the ones that we need to. One thing about that, Glenn, and I think you were involved in this case about the good things that happen in hospitals. Here you have early on in the technology that goes on in this country is remarkable, but they've had these clot busting drugs. And we were one of the first hospitals in the state working with our emergency department physicians to assess patients that come in with a stroke. The physicians would assess them. They'd get a neurologist. They'd get an MRI. And if the individual was eligible for these clot-busting drugs, the physician would administer them. One of the first patients that we dealt with, I don't know if it was you, Glenn, or it was about that time when you were at the hospital. But this patient came in completely paralyzed with a stroke. They went through the protocols, gave the drug to the patient, and 3 days later, they walked out of the hospital. There is remarkable things that are going on with technology, new medications, and actually the provision of care that can't go understated. And I think that unfortunately hospitals have not championed the good things that go on enough.
Actually, in one of our earlier conversations here, we had Dr. Philip Enty, the neurologist, come on and speak, and he was the one that was bringing that clot-busting medication to the community and to the area.
Yeah, Phil Barry Coughlin, the ER docs, and they all set up the protocols, and it was amazing. I remember how excited the physicians were. I think I was talking to Phil. He said that lady just walked out of the hospital after being completely paralyzed. So It's amazing stuff. And that goes to the benefit of being a small town. Someone that gets paralyzed and get to the hospital in 5 minutes, the quicker you give those medications and assess it. So it's good stuff.
Jim, do you have another minute?
Yeah.
I want to ask you, somebody moves into a new community. Do you think it's a good idea that they go to the hospital when they're feeling well and introduce themselves, look at the emergency department, meet the administrator, meet some people, or just wait until they come in through a 911 system?
It's probably not a bad idea. I think it's, Glenn, that's one of the things. It's very difficult to determine the quality of a physician or a hospital, a lay person. Some of the some of the nicest physicians that you would run into or talk to, have some of the best bedside manners, may be the physicians with the least clinical skills. And some of the physicians with the worst bedside manners may be the greatest clinicians. And so, but people's perception is so much on, do I like this doctor, which really has nothing to do with, doesn't translate into clinical competency. And so, I don't know, Glenn. You just have to kind of keep your ears to the tracks and make sure that you're getting taken care of. And I don't know if there is a place that you can go to. And I'm sure, Glenn, you and I have both been at parties where they keep talking about how wonderful this doctor is. And we sit there and, probably neither one of us would ever go to the person. But, the perception is that they're such a nice person and they've got to be a good doctor. And so, when you're at a cocktail party or something and they're talking about what a great doctor someone is, to me, it's like a grain of salt. I would take a recommendation from another doctor, a doctor I respect. In fact, I think I told you before we started the program, Barbara ended up breaking her foot, my wife. And, we drove back to Lompoc because I know the radiologist, I know the orthopedic surgeon, I know that the person he's going to refer me to, we ended up being referred out to Santa Barbara to a foot ankle specialist. And I know the person he's going to refer me to is someone that is very competent. And, I'm just comfortable in this environment that we're going to get good care.
I am grateful to my very special guest and friend, Jim Raggio, hospital administrator, CEO of Lompoc Valley Community Hospital, for sharing his wisdom and expertise with us. I look forward to meeting with all of you again, and Christina, in another quadrant of the healthcare galaxy as we search for optimal health. And until we see each other again, I wish you all optimal health. Thank you, Jim.
Thanks, you.
Glenn. Thanks, Christina.
Thank you so much, Jim. It's been an honor to have you on here and also to help us, to give us laymen out here an understanding of what you have to deal with and what really is behind the scenes that are going on in the hospital to make us feel more comfortable about actually stepping in and what to expect when we're there, receiving the care that we need at that moment, at that present moment. And also what to expect after. So it's not, a bit of a shock.
I understand.
Thank you so much. It's been a pleasure.
All right. Bye-bye.
Bye-bye.